Hello, everyone, and welcome to the Health Equity Jam session for April 2022. We were a little bit worried for a minute there because I didn't see folks, but I think we sorted out our little technical glitch. My name is Lisa Cooper, and I'm director here at the Johns Hopkins Center for Health Equity. And it's my pleasure to welcome you to our jam session today, where our featured guest speaker is Dr. Kelly Bauer. And so I'm going to start out with a brief introduction of Dr. Bauer, and then we'll move into our usual fun facts. And so the music we were enjoying just now, I'm sure many of you recognize the lovely voice of Ed Sheeran, one of my favorite artists. So I don't know if he's Kelly's or not, but that's who was playing, and we like him. So we're happy about that. But Dr. Kelly Bauer is going to be speaking to us today about her work. She is an associate professor in the Johns Hopkins School of Nursing. She's also associate director at the Johns Hopkins Urban Health Institute. And so we are very fortunate to have her there. And she's a senior faculty fellow at SOURCE. She's actually one of the co-PIs of a new project in the Mid-Atlantic Center for Health Equity as well, for cardiometabolic health equity. And it's called Healthy for Two Home Visiting, right? But Kelly has practiced as a public health nurse for over 20 years, and her research and public health practice focuses on the elimination of racial disparities in women's maternal and infant health. And she's received funding from the Health Resources and Services Administration, as well as the National Institutes of Health. She earned her MSN from the Johns Hopkins School of Nursing and her MPH and PhD from the Bloomberg School of Public Health. And she's also a mom to 3 active boys. So I don't know how she does all of this, but maybe she'll tell us a little bit more about that this afternoon. So before we move on, we're going to have a few fun facts here, so get ready to see if we'll see how on top of it you guys are and how well you know Dr. Kelly Bauer. So first, let's have some guesses about some of Kelly's favorite places to travel and visit, because apparently she's an avid traveler. So let's see if we can get some guesses of what maybe 1 or 2 of her favorite countries might be to visit. And you can type them in the chat. Oh, well, Greece sounds like a nice place to be. One of the other places, unfortunately, it's not one of Kelly's favorite places, but it has some things in common with another place that she likes, in that it has lovely beaches. Italy, Spain, these are all great Mediterranean guesses, but not right. You're not even on the right continent. How about that? So let's think of some other continents here. Well, okay, we have Nigeria. I knew that would come up at some point during the jam session. Nigeria seems to come up quite often. Argentina, well, I see, bing, we've got 1 correct answer here. South Africa, yay, and we have another one, Thailand. So great, I guess it didn't take that long. So Thailand and South Africa are 2 of Kelly's favorite countries to visit. She's an avid traveler. There are some other interesting things about Kelly that I am just learning. So, you know, she does strike me as sort of like a wholesome, maybe physically active person. So I would love to see some guesses about her favorite sports. I mean, does she look like a golfer or basketball or tennis player? Or, okay, I see soccer, chess, running. These are all sort of very conventional. Well, I see 1, skydiving. Okay, somebody here knows Kelly Bauer pretty well. Who is that? Looks like Erica Protaska knows something about Kelly Bauer. So skydiving, that was one of them. There's 1 more, and it's not kind of your regular thing, let me just say. If you like skydiving, think about something else that's very adventurous. Well, snorkeling is getting closer. There we go, scuba. Thank you, Nancy. And deep sea diving, yes. So Kelly is really, she's not sitting at home.
I do feel like I have to clarify this by saying that in some previous life I had a decade or so ago, I was adventurous and did fun things like that. My last 10, 15 years have been adventures in parenting, but
I was going to say 3 boys and skydiving.
Once, just once.
Yeah. Well, so the last question is going to be a lot of fun. There's one person who's not going to be allowed to answer this question. But anyway, well, they might be able to. One person on this call, you may know who you are. You may be disqualified from answering this question. Let's just say you probably will know who you are as soon as I get started with the clues. So there are 3 clues to this. Now, Kelly Bauer has something in common with Dorothy from The Wizard of Oz. So I want you to guess what it is. I'll give you 3 different options to choose from. 1, she loves red shoes. Loves them. Ruby red shoes. 2, she has a dog named Toto. Or 3, she comes from Kansas, grew up in Kansas. So those are the 3 clues. I see people are guessing and guessing. What's all this Kansas stuff? Well, you guys are right. You're smarter than I thought you were. I thought people were going to say she liked red shoes. She looks like a red shoes kind of person, doesn't she? I mean, if you like skydiving and scuba diving, you can surely get away with wearing red shoes.
I only remember owning 1 pair of red shoes in my life, but I did enjoy them.
Yeah. So anyway, yeah, so tell us more, Kelly, anything else more you want to tell us about growing up in Kansas or any of these other exciting, fun facts about you?
Well, I will say, growing up in Kansas there, and we're going to talk today a little bit about stereotypes and biases. And there's certainly some stereotypes when people think about Kansas. It conjures some like images of Dorothy and Toto and very rural areas. And when I went to college on the East Coast, people couldn't believe I was from Kansas. It was just blew their mind. And I would joke that I grew up without running water in my house, or that I rode a horse to school, and people would hook, line, and sinker believe it. So, but I didn't. It was very suburban area outside of Kansas City where I grew up.
Well, you have something in common with at least one other person on the call, Jackie Batrai, who is in the Center for Health Equity and is also from Kansas.
Oh, I'd love to.
Yeah, so I lived by the plaza and also in Lawrence for some time.
Oh yeah.
Where did you live?
Just I grew up in Overland Park, so on the Kansas side, just like 15 minutes from the plaza. Yeah.
Yeah, great. It's I know. I get all those comments all the time too. What was it like living on a farm?
Yeah. Yeah, were there any McDonald's there?
Well, don't feel bad. I thought they were only like Africa questions because I grew up in West Africa, and of course people always wanted to know whether people lived in trees and crazy things like that. So some other things that won't be mentioned on this call.
Yeah.
But anyway, okay, well, those were our fun facts, and we want to make sure that we have enough time to hear from Kelly. So while she's pulling her slides up, we'll just say we look forward to hearing today from Dr. Kelly Bauer about her work in the area of maternal and infant health disparities.
Great. Well, thank you. That was really fun. That lived up to, I was telling Lisa that I saw a colleague yesterday who was saying how much they loved the jam sessions, and they were so fun at the beginning with the music and the fun facts, and that lived up to the hype. So thank you for that warm welcome. It's really nice to be here, see some familiar faces, from folks who I don't know. Just really nice to be here, and thank you for the invitation. So we're going to talk a little bit about some maternal health equity and sort of public health practice and research in the space of maternal health equity. And I think that a lot of people have seen the headlines and know these two very famous women, Serena Williams and Beyonce Knowles. And really, since the two of them gave interviews to Vogue in 2018, we've seen a lot of media attention being given to the issue of Black maternal health and the crisis and racial disparities that we know exist. Serena Williams, for anyone who isn't familiar, gave birth to a baby girl in 2017 and suffered a life-threatening pulmonary embolism. She has shared about that experience and how she really had to self-advocate for herself in making sure that she received the care that she needed and that she was listened to when she knew that there was something wrong. And Beyonce gave birth to twins in 2017 and had a C-section as a result of sudden onset preeclampsia. And both of them shared their stories in Vogue and have brought some really important attention to this issue. You all can see my slides, right? And just my slides? Yeah, okay, thanks.
Yes.
Great. Again, this important media attention we've been seeing a lot of since the time that they both came out to really identify the fact that we are facing a variety of public health crises, but the crisis of Black maternal health is really an important one. So I'm going to talk a little bit about my program of research, which really focuses on the elimination of racial inequities in women's maternal and infant health. And we're going to look a little bit at both the understanding of structural and social determinants that underlie those inequities, and also some strategies, some public health strategies that leverage some of our existing health and public health services in order to promote health equity. And I have to start today, and I'm going to talk a lot about my practice as a public health nurse. So I'm going to talk a little bit about kind of my background in public health and public health nursing. And the sort of important piece of this is that my program of research has really been very strongly informed by the years that I've worked as a public health nurse. And my first job was at Dayspring Programs. It's about a mile from the East Baltimore campus. I was there for about 6 years. Dayspring is a housing program. They serve families who are affected by substance use disorder, mothers who are homeless and who are in early recovery are able to live there with their children. And when I went to work there, I really thought that I would be focusing most of my time on helping women to address their substance use disorder, perhaps helping them with infectious diseases like HIV or hepatitis C. But in fact, what I saw primarily was a lot of chronic disease in really young women. These were women primarily of childbearing age. They had young children of their own, and they were suffering from hypertension, diabetes, things that we might expect older individuals to experience, and quite a bit of obesity and overweight among the women who I worked with. And it was very obvious that while we worked on managing those diseases, we also were working towards prevention and lifestyle and behavioral interventions to address hypertension and diabetes. And it was really hard because the environment in which Dayspring exists and the building is situated was really a food desert. There wasn't a lot of spaces to walk. And it was really the start of my interest in neighborhood and environmental research and looking at those social and structural determinants of health. I then went on to work as the clinic coordinator for the Caroline Street Clinic for the Uninsured, which was an early UHI initiative. And again, we provided free primary care for adults, about 40% of which were Spanish speaking. And again, here we saw a lot of chronic disease, particularly cardiometabolic diseases. And I always like to say, so I started my dissertation when I was working at the Caroline Street Clinic, and the topic of my dissertation was racial residential segregation, food store availability, and racial disparities in obesity among women. And I think that these early experiences in my public health practice really inspired me, or made me really passionate about going upstream, looking at those social determinants, thinking about what is it that is creating these food deserts? What is it that is making it so difficult for neighborhoods to provide the resources that families so desperately need to have good health. And then I went on to work for Be More for Healthy Babies in the Baltimore City Health Department, which I'm going to talk quite a bit about. And I'm more recently doing some work in the space of home visiting, which I will also be talking about. So again, all of that time sort of inspired my interest in structural and social determinants of maternal health disparities. And those disparities, just very broadly, to be sure that everybody understands and to contextualize this, we know that compared to white women and infants, that Black women are 50% more likely to have a preterm birth. Preterm birth has been cited as one of the primary drivers of racial disparities in infant mortality. We know that Black infants are more than twice as likely to die in the first year of life. Black women are 2.5 times more likely to experience a pregnancy-related complication. Those types of complications might be things like gestational diabetes or preeclampsia, which is acute hypertension in pregnancy, cardiovascular events, infection, hemorrhage, things of that nature. And that Black women are 2 to 4 times more likely to die from a pregnancy-related complication. And I think it's important when we're thinking about just the basic epidemiology of maternal health and the racial disparities that exist is to understand that this is not a matter of SES or socioeconomic status. Income and socioeconomic status does matter when we look at the rates of infant mortality, maternal mortality, but it doesn't fully account for the racial disparities that we see. We know from the literature that college-educated Black women are more likely to experience a pregnancy complication than high school-educated white women. And this very poignant story of Shalon Irving is an example of that. And I think many on this call know her to be a friend of Johns Hopkins. She was a graduate of our PhD program at the School of Public Health. She was a lieutenant commander in the Commissioned Corps of the U.S. Public Health Service and an epidemiologist. And she herself studied racial inequities. And she died several weeks after childbirth, despite presenting to her healthcare providers complaining of symptoms of high blood pressure. So the question really is why, and you know, our science has shown that there are, of course, a variety of medical and behavioral risk factors that contribute to pregnancy-related outcomes, and like preterm birth and low birth weight, but we really haven't yet, and through our research, fully identified the drivers of racial disparities. We do know, and this article is another piece of popular media that does a really nice job of identifying that really probably racism, not race, is the driver of these disparities, and that it's really has a lot to do with the lived experience of being Black in America. So the reason that I entered into this space really has to do with my public health practice. Again, in my early practice, I was working at Dayspring, which is close by to here, the medical campus. And then in 2009, I started working with the Baltimore City Health Department's fetal infant mortality review. And for anyone who's not familiar with FEMOR, it's a common public health approach that you can find in a lot of local jurisdictions. So Baltimore City has a FEMOR. Other counties in Maryland have their own FEMORs. It's intended to be a very local public health practice where multidisciplinary teams really look at all of the instances of fetal and infant death and review those cases and try to really be thoughtful about what are the contributors and make recommendations that are more systems level recommendations for how we can improve care and hopefully prevent future fetal and infant deaths. You can, so what goes into this is, medical record reviews, maternal interviews, and social service record reviews. So all of the medical records for the prenatal care and other care of the woman and infant get reviewed and presented. There is an opportunity for women who have experienced a loss to have an interview. And I was really honored to be the maternal interviewer for FEMOR for many years and conducted those interviews with women who had experienced a loss. And social service record reviews gave a fuller picture of, the types of services and programs that a family may have been engaged in. And I think as with many things that, one of the risks of FEMUR, though it has a very strong focus on systems, is that it could potentially inadvertently perpetuate victim blaming, stereotyping, biased perpetuation of biases. But I think that Baltimore City Health Department has really one of the most innovative and sort of forward-thinking FEMURs in the country. I've done a little work nationally with FEMUR, and they were very careful to center social determinants of health. They created maps where you could see where the family lived and what were maybe some of the resources available. Maybe, was this a food desert? Was there air pollution? A lot of liquor stores, et cetera. So you got a fuller picture of the life of the family. And we also were able to add some questions into the interviews of women, really asking about their experience of care and asking about any experiences of discrimination across a lifetime and in their medical care. And so all of that data went into a case review. So a multidisciplinary team came around the table, public health professionals, hospital staff, healthcare providers, community organizations would review the case data and try to understand and identify some of the systemic issues that might have been contributing to that fetal or infant loss. And one of the really wonderful things that the health department, Baltimore City Health Department, did in their case review team was they added women to the case review team who had lived experience. So not just having a whole bunch of healthcare professionals and others at the table, but included women who had actually experienced a fetal or infant loss to help with the review of these cases, to help with the recommendations that were being made. And then what happens, so then what happens is it moves to community action, and I'll talk a minute about that. But in the time that I was at the health department and working with FEMUR for those 10 years, the primary causes that we were seeing of infant mortality were related to preterm birth and low birth weight. So that is heavily contributed by maternal health. So maternal health is, in particular, hypertension and diabetes are really significant risk factors for preterm birth and low birth weight, maternal complications of pregnancy, and then sleep-related deaths. And when FEMUR sort of looked at what was the cause of the causes, or what are the sort of the more root issues that are at play here, they identified high blood pressure. So a lot of women have coming into pregnancy with high blood pressure, experiencing high blood pressure during pregnancy, many risk factors, including overweight and obesity coming into pregnancy. They identified community and social supports as sometimes missing. So a lot of women who were under a great deal of stress, sometimes they, may have had a behavioral health challenge, mental health diagnosis, perhaps substance use disorder, or perhaps they, had family stressors, including poverty and so forth. And they weren't always engaged in the systems of support and care that we might have hoped that they would have been in order to get some support. And then another important finding and recommendation that came out of FEMUR was around provider treatment of mothers. It's really hard in this kind of case review to know if there was sort of bias in the care that the mom was receiving, but based on some of the medical record reviews, based on maternal interviews, there was some suggestion around concerns that the care that women were receiving was at times biased, and perhaps based on their race was biased. So what happens in Baltimore City is when those recommendations are made, they get shared with the Be More for Healthy Babies initiative. And Be More for Healthy Babies is a citywide initiative to reduce fetal and infant morbidity and mortality. And they take those recommendations and they feed them to their coalitions that are all part of BHB. And these are the current coalitions under Be More for Healthy Babies. These bring together professionals from around the city. They're in partnership with about 150 organizations, all of whom are also really concerned about fetal and infant mortality and morbidity and family health and maternal health. And they come together around these topics. They take information from FEMUR and work towards solutions, sort of pool their expertise, pool their resources, and work towards solutions in these different topic areas. I was very fortunate to work with the equity work group and also with the Baby Stat Home Visiting work group, and I'll talk a little bit about both of those. The equity work group did a lot of very intentional work around anti-racism. They did a lot of extensive training. They worked very hard to center racial disparities as the primary issue that they were tackling. And out of some of that work, while BHB had been engaging community throughout their initiative, they really wanted to center community voice and make sure that they had a structure by which they were accountable to community voice. And so I was really fortunate to receive an academic community grant from the Urban Health Institute, and we were able to fund the development and now ongoing implementation of a community advisory board. And so this is their structure for BHB, and you can see that the advisory board is right there and is one of the bodies to which BHB is now accountable. And so that was a really exciting way to center community in the work that BHB was doing. The other thing that we were able to do with that community advisory board was just to have a little further opportunity to explore this recommendation out of FEMR, where they, said, well, we think that there's sort of bias and maybe racism in care, but we, can't always get at it through our medical record reviews. And so with the CAB members, with other community members, with home visitors who were working in Baltimore City, we conducted some focus groups to talk about racism and how it impacts the health of moms and babies in Baltimore. And a variety of themes emerged, but one of them was this issue of bias in care. A few of the quotes that we recorded are here. One person said, before they say, hello, how are you? The first questions were, how are you sexually active? How many partners have you slept with? Do you use condoms? All these things. And I'm married, so I'm looking at her like, okay, you didn't even ask anything. You just looked at me and just assumed that like I had all these sexual partners. Another person said, and they're treating her like, well, you got yourself into this situation. And if you had a husband or some close boyfriend or whatever, you would have that support. And a lot of times I think people say some really bad things to young girls, when they're pregnant and they're getting ready to deliver, like they blame them. And then the last one, literally her incision from a C-section was opening up and they're like, oh, you're okay. Like you'll make it through. Don't worry. You don't need any pain medication, things like that. And she's literally sitting there in 10 out of 10 pain. And they're like, nope, it's like, you're tough. You can make it. You're good. You don't need it. That last quote we know is sadly also reinforced by some empirical literature that tells us that Black patients, men and women, don't always have their pain adequately treated. So this sort of mistreatment in care or bias in care came out as an important theme in the work we were doing with BHB. And I do have to say that, of course, this work was not the first to raise the alarm bells on these issues. For many years, Black women scholars have been talking about and studying these issues and sometimes not being listened to about those issues. This is a really wonderful sociologic study that is called Battling Over Birth, where a group of 100 Black women in California were interviewed, and they described their encounters with maternity care as a source of stress and conflict. They didn't feel their wisdom about their own bodies was being listened to, and lots more wonderful information in that publication if you're interested. So all the while I'm doing all of this public health practice, working with FEMR, working with Baltimore City Health Department with BHB, I also had an opportunity to work with Phyllis Sharps and other colleagues at the School of Nursing to do a literature review looking at racial discrimination and adverse birth outcomes. And this was a follow-up to a review that had been done several years prior, and that prior literature review as well as ours both concluded that the current state of science and what we see from empirical literature does find in fact a positive association between racism and adverse birth outcomes, and so we followed that up with a study using a national data set. One of the things that was missing in the literature was a more nationally representative look at the relationship between racism and birth outcomes. So we did a follow-up using pregnancy risk assessment monitoring system data, or PRAMS. PRAMS is a nationally administered surveys administered by states, and then aggregated nationally. They interview women in the year following birth. States are able to select, well, there are some core questions that all states have to administer in their PRAM survey, and then some states are able to select, or all states are able to select some additional questions that they want to ask. So the time of the study and in the study years, there were 11 states plus New York that were using a question in their survey that asked about discrimination and care. The question asked, during the 12 months before your new baby was born, did you feel emotionally upset as a result of how you were treated based on your race? So we took the sample of non-Hispanic Black mothers who had delivered in 11 states that asked this question, plus New York City, and in fact did find that those who reported feeling upset by experiences of racism in the 12 months prior to birth had a 1.2 greater odds of preterm birth compared to those who did not report feeling upset due to experiences of racism. There is less literature, existing literature, that looks at the association between racism and maternal outcomes. So we also have done a follow-up to this using PRAMS data, again, using those same 11 states and the same question, where we have looked at perinatal depression and racism. And again, have found that there, for those who reported feeling upset due to experiences of racism, they had a twofold higher odds of experiencing depression during pregnancy compared to respondents who did not. So I will say, you know, one of the real limitations to some of this work is that there's a single question that's asked in these states about racism. It is limited in the sort of conceptual clarity that it can provide us in terms of understanding the type of racism and experiences women are talking about, the context in which those experiences occur, the lifetime experiences of racism that many experience, so not just the 12 months prior to pregnancy, but the leading up to and experiences across the lifespan. It doesn't distinguish between acute racism and chronic racism across the lifetime. So, you know, there is really a need in these national data sets, these national surveys, to do better, I think, questioning around these questions of racism so that we can continue to hone our understanding of its impact on a variety of outcomes. So in the years that I was working with FEMR and the health department and BHB, and I had so many lessons learned, so many take-home messages, so much that I'm really grateful for in sort of forming my interests. But a few of my take-homes were, you know, really that efforts to promote maternal health equity have to address structural determinants of health like racism and bias. That addressing maternal cardiometabolic health is really a priority in terms of closing the gap in racial disparities and fetal and infant mortality. And that health equity work has to be collaborative. You know, BHB did such a beautiful job of bringing together so many partners with different resources and expertise and skills. And, you know, that the way towards that health equity, I think, is really through that collaborative approach, centering equity, centering anti-racism, and collaborating with multidisciplinary partners. So, so I'm going to sort of switch gears and talk a little more about some of my recent work and how to take sort of some of those lessons I learned in my early career as a public health nurse and leverage what are the existing systems of care in order to promote maternal health equity. I was making the slide and I was thinking about Monica McLemore, who was here speaking at Hopkins maybe a year or two ago, sometime during the pandemic. She's a real giant and leader in the space of maternal health, reproductive justice. And she talked about retrofitting, reforming, and reimagining different systems in order to address promote reproductive justice and address these disparities. And I would say that, this work that I'm have been doing most recently is in that sort of like retrofitting and reforming. How can we really retrofit or reform our existing services to better address maternal morbidity and mortality and infant morbidity and mortality and promote health equity? So in Maryland, very specifically, I gave a little bit of information about sort of the state of maternal and infant health nationally, but in Maryland, we know that our maternal mortality and severe maternal morbidity are consistently higher than what we see nationally. Each year in Maryland, about 1,500 mothers experience a life-threatening pregnancy or delivery complication. Unintentional drug overdose has become, in the recent past, the leading cause of death in the year following pregnancy in Maryland. Most of those deaths are among white women. And over 80% of maternal deaths are preventable or potentially preventable. Here in Maryland, we also have a maternal mortality review committee. So it's somewhat similar to that FEMUR process, where they review all of the cases of maternal mortality and death. And I'm not a part of a maternal mortality review committee, but they are the ones who, in reviewing these cases, have made this statement that over 80% of the deaths that they've reviewed in the state of Maryland are preventable or potentially preventable. And then finally, work by colleague Andrea Krienga looking at Maryland hospitals found that hospitals that had lower patient experience of care, so lower patient ratings of their care in the hospital, also had higher rates of severe maternal morbidity or illness during pregnancy. And again, we know that there are significant racial and ethnic disparities in Maryland. So non-Hispanic Black and Hispanic women have a 2.6 times and 1.4 times higher risk of dying from pregnancy-related causes compared to their white counterparts. And non-Hispanic Black women experience severe maternal morbidity at disproportionately high rates. So several years ago, just prior to the pandemic, I had the opportunity to be a part of a 5-year state maternal health program called MD Mom or Maryland Mom. It's funded by HRSA. There are 9 other states in the country that received the similar state maternal health innovation award. And it's a collaboration between Johns Hopkins, the Maryland Department of Health, the Maryland Patient Safety Center, and the University of Baltimore, or University of Maryland, Baltimore County. This is sort of an outline of our work plan. On the left column, there's sort of 2 main, I guess we could say, buckets of work that we are undertaking. And one is really in the space of improved data availability and utilization. And much of that work is led by my colleague, Andrea Krienga, who's also the PI on the MD Mom grant. And then the other bucket is really around innovations in maternal health service delivery and ways, strategies to really address maternal health and reduce maternal morbidity and mortality. And so in the bucket of data utilization, I won't talk too much today about that because it's not work that I personally lead, but it's really exciting work. The first area is around just disseminating the data and findings of the Maryland Maternal Mortality Committee, because they are doing a lot of important work, have important findings that our community, our other stakeholders need to know and be aware of. So we are creating data briefs and publications and trying to disseminate more widely those findings. Establishing a severe maternal morbidity surveillance and review process. So again, in Maryland, we're fortunate to have a mortality review committee. Not all states do, but we don't do as good a job with surveillance of the severe maternal morbidities or the illnesses in pregnancy. And so we've established a surveillance system working with, we started with the pilot of about 9 hospitals where they are actually extracting and sharing specific data about all of the cases of severe maternal morbidity that occur in their hospital. And then we're able to aggregate and start better understanding the maternal morbidity in the state. On the right-hand side, under innovations in maternal health service delivery, the area in sort of cream is the hospital initiative, and that's much of the work that I lead and we'll be talking a little bit about here in a minute. We have work that's really focused on, training and quality improvement efforts to promote equity in that square there. We also have a perinatal telemedicine network, and I've been a part of also our work to educate women around the warning signs and urgent maternal warning signs related to severe morbidities, and distributing that through home visiting programs. So I'll talk a little more about that also. So one of the things we've had to do in MD Mom is really get into partnership with the birthing hospitals in Maryland. So there are 32 hospitals in Maryland that have a labor and delivery and postpartum unit. And so we are very, proud and, feel fortunate to be in relationship with and have contacts at all of those hospitals who we meet with regularly. If you're interested, this is an interactive map on our website, mdmom.org, if you want to learn more about the birthing hospitals in Maryland. And the hospital initiative, the area that you saw there in cream, really is around training and quality improvement in the space of health equity. And again, I saw this as really an exciting opportunity to address some of the issues that we were seeing through FEMR, and that BHB had really prioritized as a need in the space of maternal health. And so the first thing that we're doing is a series of trainings around implicit bias. So we have an implicit bias training that is both an online training followed by 2 skill building sessions. I'll talk a little bit more about that. And then we also are about to roll out a training that's talks about bias in the care of pregnant people with substance use disorder. Again, we know that that's a leading cause of mortality in the year following pregnancy here in Maryland. And we also know that there's a lot of bias and stigma in that space. And then coming soon, something that we're working on, we're finishing year 3 in September. So we're a couple years into the grant, but the Maternal Health Equity Toolkit is really focused on going a step further. So while implicit bias training is necessary, it is likely not really sufficient for addressing these issues. And so we're putting together a set of strategies that are out there and available through IHI, through the Black Mamas Matter Alliance, through other organizations who are doing this work, but trying to make a very practical guide and resource for hospitals to access the information around how do you take more of a structural approach to ensuring that you're providing respectful and equitable care on your labor and delivery and postpartum unit. Things like a culture of equity, leveraging data, making sure we're looking at our data and seeing the disparities, linkages to community and other services and so forth. So a couple things happened as we were starting this grant. We started the grant in 2019 in September. And then of course, in March of 2020, COVID happened. So that did adjust things a little bit for us, but also in early 2020, the Maryland General Assembly passed this legislation to mandate implicit bias training for perinatal care providers by the end of 2021. And so that certainly was a positive thing for our work, and was, I think, somewhat of a motivating factor for hospitals in participating, but there was not a lot of enforcement behind that legislation. And so then in 2021, there was additional legislation that mandates in Maryland implicit bias training for all healthcare providers in order to renew their license. And that's starting this month, actually, in 2022, April of 2022. And that has a little more enforcement built in. And so we are seeing a little more activation as a result of that legislation. But to tell you a little bit more about the implicit bias training that we are offering, we were initially in our grant going to create our own implicit bias training because there weren't any existing implicit bias trainings that were really specific to the setting of maternal health. But as we started our grant, a lot of things had, developed and emerged, and the March of Dimes had created a wonderful online training. So we offer a 1-hour online training that was developed by the March of Dimes. They do a really nice job of not just explaining implicit bias and some of the cognitive science behind it, but also really describing how structural racism contributes to bias and setting that stage and that context. They talk about the ally model as a way to interact with patients and avoid bias. And we've been really happy with it and gotten a lot of really good feedback from our hospital partners about this. But again, we felt like a single online training, again, was necessary, probably not sufficient. And while the March of Dimes training was very, very good, very high quality training, it doesn't really have the time or opportunity to go into a lot of the more sort of specific skills around how to actually mitigate bias in our care. And so we partnered with the Hopkins Medicine Office of Diversity, Equity, and Inclusion, and we developed a 2-session skill building session that's based on the ally model that we deliver virtually, of course, because of COVID, but as a live offering where we meet with hospitals, their physicians, nurses, other staff, and we really go through the ally model, which is avoiding assumptions, learning about the whole patient, listening to the patient, and yielding to the patient. The sessions are really designed to be conducted like workshops. They include a video module where they see, biased care and then correction of that. It includes interactive questions and answers. It is co-led by an expert in implicit bias, along with a clinician who has expertise in perinatal health. And again, we've gotten really good feedback, though they, are really some pretty simplistic skills that we're trying to train folks on. So, pausing for a moment before you engage in a clinical situation to see if you may have some preconceived notions about the patient, using active listening skills and open-ended questions and so forth. So, but we've again gotten some good feedback. So we are really proud to say that our online training has been completed by 2,368 Maryland maternal health care professionals. So that's physicians, nurses, techs who are working in labor and delivery and postpartum units. All 32 of the birth hospitals have engaged in this training and have at least some of their staff trained. Our highest hospital completion rate is 68%. Our average hospital completion rate is 68? Our highest hospital completion is 98%, and our average completion rate is 60%. And at this point in time, over 75% of the 12 of the hospitals have over 75% of their staff trained with this online training. And counting. We rolled this out starting about this time last year. Different hospitals have adopted it at different times. Thank you, Natalie. But we think that there's about 4,000 healthcare providers, maternal healthcare providers in the state. That's our best estimate based on our conversations and data from hospitals. And so we're really excited, and we expect we'll probably get to about 3,500. And then the skill building session started at about the end of last year. So we've are a little newer just to working on those. And we have, we think about 300 health professionals trained. We don't have the attendance from every single one of our 20 skill building sessions at this point in time. But 11 hospitals have engaged in those. And again, and counting, we continue to schedule them with hospitals around the state. And then I can't share too much yet about the implementation of our managing bias in the care of pregnant and parenting people with substance use disorder, but we've partnered with Mishka Turplin, who's an expert in the field of substance use and pregnancy. He's an obstetrician and also an addiction medicine physician, and have developed an online training that talks about substance use as a chronic disease, talks about stigma and bias and how it impacts the quality of care that we provide. Looks at the postpartum period as an especially vulnerable period for people with substance use disorder. Again, remembering that our highest rates of mortality in the state are in that year postpartum come from overdose, and look at ways to mitigate bias in the care of people with substance use disorder. So the hope is that this builds on the trainings that folks have been involved with that are more focused on racial and ethnic bias, but use the same skills to think about how we may have bias in caring for people with substance use disorder, especially pregnant people, where there really can be a lot of bias. And I'm really excited. We have patient testimonials, women with lived experience, who will be providing testimonials as part of that training, and will be available next month, we hope. So we are still working on evaluating these initiatives. Rigorous evaluation is, of course, an important element. We did administer a baseline survey prior to the start of our implicit bias trainings, and we won't collect our follow-up survey until probably the end of this year, beginning of next year. But we are excited to look at those results. One of the things that we really wanted to do was think about how can you evaluate implicit bias trainings. Implicit bias trainings, while they are being widely recommended by state legislations, by professional organizations, ACOG, and which is the American College of Obstetricians and Gynecologists, as well as ACNM, which is the American College of Nurse Midwives, and A1, which is the Association of Women's Health, Obstetric, and Neonatal Nurses, all have recommendations around implicit bias training, but we don't have great evidence for the effect of implicit bias training. And of course, what we're hoping ultimately is that implicit bias training impacts the experience of care, the quality of care that women receive. We had really hoped to be able to measure that in the MD-MOM project. It turns out getting patient experience of care data is challenging, and COVID really complicated those challenges, given that we couldn't walk into hospitals and onto units the way that we could pre-COVID. So we thought about trying to measure some more proximate indicators of effectiveness of implicit bias training, but there really weren't any valid and reliable measures to do so. And so we decided to develop our own instrument. We've titled it Bias in Maternal Care. We went through a 3-phase instrument development process, have a great statistician, Saifuddin Ahmed, in the School of Public Health, who we've worked with on this. And started with some literature review and expert review of the items, reduced that down to 33 items, conducted some factor analysis. We used a sample. Our phase 2 sample was a sample of nurses and midwives, 300 nurses and midwives. And then we went on to validate it using our baseline data and the sample of providers in Maryland. So we have a sample of 2,100 maternal health professionals who completed that baseline survey before starting implicit bias training. So we were able to validate the measure with that. And so we ultimately came up with a 23 item measure. It has 3 scales, has good, Cronbach's alpha reliability for the statisticians in the audience who are interested in that. One subscale is bias awareness. So these are the questions on the bias awareness subscale. And then the other 2 subscales are bias mitigation self-efficacy and bias mitigation practice. So these differ only, it's the same set of 7 questions, but they differ only by my self-efficacy. So I feel confident that I can identify my own biases while performing patient care, or whether or not you've actually practiced it. I identify my own biases while performing patient care. And we envision that these can be used for different purposes. So, if you're doing an immediate post-test, you probably wouldn't be measuring practices because people wouldn't have had a chance to make practice change. But you might use confidence. If you're doing more of a longitudinal look, you could use practices in an evaluation. So I probably don't have a ton more time, but I'll just do one more shift towards home visiting to talk about one other public health service where I've been able to work a little bit in the space of, again, retrofitting, reforming. How do we engage with this important public health service to promote health equity? Maternal, infant, early childhood home visiting is also referred to often as McV. McV is actually legislation that was passed in 2010, where the US government invested a lot of money into home visiting. Home visiting is not home health care. It gets sort of confused in that way, but home visiting is really sort of more on the social service sector. They provide home visits. There's a home visitor who can be a nurse, but most often is a paraprofessional, a trained community member. They make regular visits to pregnant and postpartum families. And they provide information about parenting, about health of the mother, of the child. They work towards school readiness, and they do a lot of linkages of families to community resources. They screen for a variety of different issues and conditions. And home visiting is happening in all 50 states in the US. So you may not know if it's happening in your community or not, but likely there is a good probability that it might be. And these are some of the aims of home visiting. They're working to improve maternal and newborn health, improve school readiness, reduce abuse and neglect of children, improve family self-sufficiency, economic self-sufficiency, reduce domestic violence, and improve care coordination. And there are 19 models of home visiting that are eligible for MCV funding. There are actually probably even more. There are home visiting programs that are out there and being delivered through health departments, through nonprofit organizations that are not MCV eligible, meaning they haven't met the threshold for having an evidence base of meeting those benchmarks that I just mentioned. But these are the 19 models that MCV or the federal government will basically give money to in order to be delivered in high-risk communities. And because of some of my work in the Be More for Healthy Babies and doing some projects with their home visiting programs and really getting to know that work, I've started to work some with Ann Duggan and the Home Visiting Applied Research Collaborative here at Hopkins. And one of the things about home visiting is that, again, because there are so many different models, they have different priorities. And so only 6 of the 19 home visiting models in Maryland really designate improving birth outcomes as an intended outcome. So of the 19, there's only 6, sorry, this I may have said in Maryland, but of those 19 that are delivered nationwide in different communities, only 6 of them look at birth outcomes as a primary focus. We conducted a survey with 5 of those 6 models, and within those, only 1 prioritized hypertension as an important outcome and 2 prioritized diabetes as an important outcome. So home visiting is really this opportunity where home visitors are in relationship with families. There's trust, there's support that they're receiving, and there's lots of opportunity for education and information to be exchanged. So one of the things that MD Mom has also done is to develop some urgent maternal warning signs education materials. The flyer on the left is a poster that was developed by AIM, or the Alliance for Innovation on Maternal Health, which is a quality improvement initiative around maternal health. And we developed patient-facing videos to go with it. These are available on our website. One's in English, one's in Spanish, to really further explain and help people understand these warning signs. You know, a headache that won't go away is an important early warning sign of hypertension or hypertensive crisis. So again, all these, excessive vaginal bleeding may be a early sign of hemorrhage. So making sure that women are aware, that caregivers and other family members are aware of these so they can help to support and make sure that women are getting into care. We've also partnered with the Baltimore Healthy Start home visiting program, and we have a training developed for the home visitors themselves so that they feel more comfortable to provide this information and education to families. And I'm also really excited to be engaged in a new project, which is part of the Mid-Atlantic Center for Cardiometabolic Health Equity. We're one of 3 studies that are funded in that center, and it's called Healthy for 2 Home Visiting. We're also adapting it for Spanish speakers, and in Spanish it's called Sanos los Dos. And it focuses on the promotion of weight loss after pregnancy and delivery to ultimately prevent obesity, diabetes, and heart disease, and reduce racial and ethnic disparities. And so the intervention Healthy for 2 was developed by my colleague, Wendy Bennett, and some of her colleagues. She's a general internal medicine physician here at Hopkins, and it's a health coaching intervention, where the participant is assigned a health coach. They work on primarily omitting high salt and high sugar foods, adding fruits and vegetables to their diet, also engaging in some wellness and self-care activities. They meet with them regularly during pregnancy and in the postpartum period. They also have home tracking of their weight. So they'll get scales so they can weigh themselves at home, Fitbit trackers, other things to sort of motivate engagement in healthy lifestyles, all with the goal of improving health behaviors that support cardiometabolic health. So smoking cessation, healthy pregnancy weight gain, and healthy postpartum weight loss, as well as physical activity and diet. So we are in the first year of that study. We just started. We're really engaging partners because Healthy for Two has not yet been available in Spanish. So we're translating and adapting it for Spanish speakers. And we're also adapting it to the home visiting setting. Wendy has had the opportunity to implement this intervention in primary care, but we're looking to see if an intervention like this can be translated or transferred into a community-based setting and be delivered through home visiting services. So we're really fortunate to be in partnership with a variety of home visiting programs around the state. We're working towards partnering with programs that serve large groups of Black or Latina clients. And we're working with programs in Baltimore City, Montgomery County, Prince George's County, and Washington County. So look forward to maybe coming back and talking more about that sometime soon. But and that is really all for me. I was sort of a lot. I have a lot of gratitude and acknowledgements for funders. I mean, Be More for Healthy Babies, who I shared a lot about here today, HRSA and NIH, who fund my two projects, and just gratitude for all of the people that it takes to help to train a person. There are so many faculty, mentors, scholars, community colleagues, students who I have learned from and engaged with along the way. And I just have a lot of gratitude for that. So, and I wanted just to share with everyone, if you're interested in more information and talks around Black maternal health, it's been Black Maternal Health Month, really. And there's a great talk coming up. I can drop this in, I can drop this in the chat for everybody if you're interested in hearing more about mothers speaking about their birth experiences. And that's coordinated with one of our partners, Baltimore Healthy Start. So thank you.
Bravo, bravo. Thank you so much, Kelly. That was just brilliant, wonderful, and so impressive, the whole breadth of your work, all the way from, starting out early in your early days, looking at infant mortality and the contributors to that, into like sort of the hospital and the care setting with, women experiencing pregnancy and birthing people, and then now into sort of the postpartum period as well. So congratulations. It's so impressive to see the trajectory of your work. And I also wanted to say that, on the President's Council of Advisors for Science and Technology, that one of the key examples I've lifted up at, as a successful sort of public health cross-sector partnership is Be More for Healthy Babies. So, that was an incredibly successful program, and it must be really gratifying to have been a part of that, because it really did reduce infant mortality in Baltimore City and actually closed gaps and reduced disparities. And so it's really a model program, I think, for the rest of the country.
Absolutely. They are just doing, I take absolutely no credit for it. I want to be really clear about that. I just feel so fortunate to have been a part of it, because it still exists. It's still ongoing. People are interested, but they really are a national model. They're really ahead of the curve, especially in the space of equity and anti-racism and that work.
So, I mean, it sounds like a lot of this work, I know a lot of people have been doing it for a long time, but you've definitely been in the trenches and now are bridging sort of academia with public health practice and with community. So thanks for all you're doing. I see a lot of comments in the chat about your talk, and Rhonda Ford Chapman offering a partnership with AHA on the nutritional strategies aspect of your intervention. The simple Cooking with Heart Kitchen. So lots of comments in the chat about how inspiring your talk is. I think I have one question, and then I'll of course open up to whomever else has any questions. You know, the whole, you know, issue around, I actually just commented on to a reporter about this issue recently because of all the state requirements being put in place for implicit bias training, which of course I'm very much in favor of, you know, having done a lot of early research on this topic. But also balancing that with the dilemma of, you know, requiring something to be done when people don't know exactly what they should be doing because we don't really know what is most effective. And so, you know, I know you mentioned that you guys are trying to capture some important outcomes, and it does sound like you are doing a lot of self-reported measures of attitudes and behaviors. Can you tell us about any other research that is being considered? Because, you know, in my experience, capturing changes in implicit attitudes is very difficult. It's really difficult to measure by self-report.
Yeah.
And then in many cases, I think what we're looking for is not necessarily a change in the implicit attitude, but a change in the behavior, right? So can you comment a little bit more on that?
Yeah, this is, I mean, gosh, this is a tough nut, and I don't claim to have really any, you know, answers. I think that's right. What the aim is to change practice. The aim is to change quality of care and patient experience of care. And those are really hard things to measure. You know, right, the ways we measure it is we go in and we observe care. And again, during COVID, that really wasn't a possibility. We ask women about their experiences of care. And hospitals are doing that to an extent. You know, different hospitals, they have requirements to do Press-Ganey patient satisfaction surveys, but the numbers that they actually administer or collect varies quite widely. And so I think there are real opportunities for advancing this, but it is going to take resources and partnership from hospitals and willingness to engage in sort of this additional level of data collection. And, you know, the instrument that we developed tries to capture both the attitudes and awareness, but also practices, and it is self-reported practice. But we did see variability in people's reporting of those practices, and so that was somewhat, I think, positive. And thinking about the utility, hopefully, of it is that, you know, that there is some space, hopefully, to move the bar. We saw some variability. We haven't fully analyzed all this data. I'd love to, you know, hope we will soon be doing that and have some, you know, post-test data to look at. But we saw some variability by hospital too, in different regions of the state and stuff. So it is imperfect, most certainly, but I do hope that it's at least a step towards that. And I hope that future work will again capture more of those actual practices and patient experiences.
Thanks, Kelly.
Yeah.
No, and I'd love to talk to you more about this too.
Yeah. I mean, gosh, we could, but yeah, I can return to the conversation if there's time and people want, but Deirdre, did you have a question? Yeah.
I did. I first just want to join the chorus of people thanking you for really a tremendous body of work and a great presentation of all of it. It's really exciting to see it all in one kind of package. I was curious, something I've just been curious about, and I think probably this applies to some other fields when it comes to health equity, but when you were presenting, I think it was some of your earlier work showing that women that had experienced discrimination, or, you know, in terms of the different sort of metrics that you had looked at, and they had a higher risk, I think it was of preterm birth, if I'm not mistaken. You know, I was curious about whether analytically, you know, you or others have or could look at the women who had those experiences who reported high levels of discrimination, but actually did have positive birth outcomes, really thinking there about whether by focusing in on, you know, what, if anything, has been able to buffer the impacts of racism for these women, that we might be able to try to bolster in intervention. So just curious as to whether that sort of flipping it on its head is something you thought about.
Yeah, and it's a great suggestion and comment, and nothing that I've seen in the work. Again, it's an interesting area of work because I think that the general consensus is that racism and discrimination does contribute to racial disparities, but the actual empirical science is still growing. I have not seen any of that work, and I love that idea. And really, probably starting with, I haven't even seen qualitative work in that sort of arena where you could look at, what are some of those protective or resiliency factors or ways in which, women are able to overcome that. So it's a great comment. Thank you.
Thank you. Are there other questions from the audience?
Erica, are you the one who knows me?
I don't know you. Actually, I didn't say skydiving. That was someone who was doing, I guess, running. So I got credit for someone else's correct response.
Oh, sorry about that.
Credit, that's fine.
So thank you so much for the talk. It was really phenomenal. I'm a pediatrician, and I was wondering, when you were doing interviews with FEMUR or in your work with community groups, did women who are being interviewed ever offer, were they ever asked about experiences within the neonatal intensive care unit or care immediately of their infants immediately after discharge from the hospital?
Yeah, this is another great question, Erica. And in the MD Mom work that we're doing, really just because of the focus that work really from HRSAs around maternal health, our focus has really been around interventions and the delivery of these trainings to prenatal and postpartum, labor and delivery and postpartum units and folks who are working with women in the pregnancy period. But we are hearing loud and clear from the NICU hospital leaders that they want their NICU staff to get this kind of training, and that it is really an issue that they are struggling with often in NICUs, especially in the space of substance use. So in the patient testimonials that we recorded for our bias in the care of patients with substance use disorder training, 2 of the women talked about having infants in the NICU and feeling a huge sense of shame and hearing nurses and others sort of disparaging them and making it really hard for them to continue to show up in the NICU, despite that and that feeling of shame and, not feeling like people are judging and treating them differently and so forth. So, so we are hearing that is a need, and I think both from patients and women, but also from our hospital partners, and hoping to expand our SUD training will definitely be available to NICU. I think without a doubt, that is something that they will get. Our implicit bias training, it's a purchased training. And so it's been a little harder, but some of our partners in hospitals, we have 2 hospitals that said, we're not doing this unless we also train our NICU. Like we're going to, because we work enough as a team between our prenatal, labor and delivery, postpartum and NICU staff. And so they purchased licenses on their own, and they are training the entirety of their staff. It's something that I probably would have done differently looking back at this, because those units do work so collaboratively, and that's such an important part of the continuum for infants, but for mothers, for families. Thanks for that.
One of the intervention strategies I've been most curious about and really wanting to test, I keep saying I'm not doing any more trials, but I have one more trial within me, maybe.
You do.
One of them is actually, I think that this whole issue of, implicit or explicit bias training or whatever for health professionals. I mean, I think one of the things that illustrates that is relevant to all of health equity research actually is the fact that intervening on one level is not likely to be successful. I mean, this is a hugely complicated problem. And so just trying to get individual people to change their behaviors is probably not enough. You have to work with individual people. You have to work with the social network that within which they exist. You have to put in sort of organizational level changes that will make it more change the context so that it's easier for people to behave in a different way. Then you also have to change policies and, so that people are accountable for certain kinds of outcomes. So multi-level, but my particular interest is in using a social network kind of approach, because I think that you can, in order to change people's behaviors, that we know that social influencers have a huge impact, right? We know that if you have people who are influential within an organization who can model the right behaviors, that you're more likely to get other people to kind of get on board with it. So I've been really interested in doing social network analysis to identify who are the people that everyone kind of looks up to, admires, whatever, and then get them to actually model the behaviors we want everybody else to do, and see if that would actually change things. Because, that approach has been used in schools. I don't know if you've heard about this, but where they train the kids that are like the most popular, influential kids to display like the behaviors they want, like for anti-bullying. And so if those kids behave in a certain way, lo and behold, the bullying in the entire school changes.
Yeah.
So I'm really interested in something like that.
I mean, it's such an interesting idea, Lisa, and I can only say anecdotally that I wholeheartedly believe you would have positive findings. I think that just in terms of the uptake of the bias training, absolutely the leadership matters, right? And their buy-in and their level of commitment matters. And even in the the skill building sessions where we're actually with the staff and stuff, you can just when the department chair or somebody in leadership position is there and they're speaking and they're modeling, you really can kind of feel how the residents are responding to that. And it really, I wholeheartedly agree. I think that would be so fascinating. And the multi-level nature of it is really important. I don't really have anything to share at this point about our equity toolkit, but it really is this idea of how do you start to change systems and how do you develop a culture of equity. So some of what you're talking about is building that culture where everybody sees this as a priority. And in our second skill building session, we talk about I'm trying to remember the term that we use, but we basically talk about how do you interrupt biased care. So if you're a bystander and you see a colleague, how do you interrupt that care? And that is the hardest thing that people have, the hardest part of the training. Trainees really have trouble talking about that and thinking about that. And I think the idea of confronting your colleague, your peer, is really threatening and difficult for people. And that I think can only change if you have a culture where that's it gets like medication errors, right? It's not threatening. It's not you're a terrible person. It's I saw this and I know you would want to know. And I'd like to support you and thinking about how we can maybe, choose a different course. And it's really, I would love to be a co-investigator on that study.
Yeah, maybe a co-PI. But no, I look forward to where this is going to go, because I think this is so important, and it's relevant not only in maternal care or even in healthcare, but actually, in broader ways in our society. I think we've seen the last few years what role modeling can do in a negative way to shift social norms. More so than probably we might have even been aware of before.
Yeah, absolutely.
But anyway, so this has been really delightful. I don't know if others have comments, but if not, before we close, well, first I want to thank Dr. Kelly Bauer for an amazing presentation today, and for really sort of pushing us to kind of think more about this critically important issue that I know is very high priority for a number of people, but nationally now, even the Vice President, Kamala Harris, has made this one of her key priorities. So I know there's a lot of support for work in this arena. So thank you, and keep up the great work, and we're here to support you. And I also want to thank our Health Equity Center for Health Equity staff who have helped to support the jam session. So we have Lauren Roars Sala, who is our communications coordinator, who did a lot of the work today. But I would be remiss if I did not call out Gia Lee, who is our superstar center administrator, because today is Administrative Professionals Day. And so I want to give a special shout out to Gia Lee. So not only for helping today, but also for what she does every day to make sure that we have all we need in terms of our administrative support, reimbursements, scheduling, who just takes care of us in general. So, and helps us to keep things running smoothly. So thank you, Gia, bravo. And we are so grateful to have you.
Thank you so much, Dr. Cooper and the team. I'm so grateful to work for Center for Health Equity.
Yeah.
And it was very nice, Dr. Bauer, today.
Yeah.
Thank you.
So, and then without further ado, we will let everyone go on and enjoy the rest of your lovely evening and look forward to seeing you again next month. All right, thank you.